Welcome to American Indian Alaska Native Workforce, Sovereignty, Career Pathways, and Increasing Access. So this is actually a workshop, one of 4 sessions, and we're starting the day out with talking about community health aid programs. So how these sessions have kind of been designed is kind of start more broadly with a community health aid program, and then we're going to kind of talk a little bit more specifically about policy and advocacy issues in terms of workforce and chat providers, specifically dental, and kind of go into and finish the day with a listening session. You don't have to attend all of them. That's why we kind of created topics that maybe align with your current work. So, but nonetheless, so we'll go ahead and get started. I want to introduce our speaker for today. And well, first off, I'm Julie. I'm going to be the moderator. And just before I introduce Christina, let me just set up some housekeeping rules. So please keep muted when you're not speaking. Looks like we've got 19 people here. So Q&A, feel free to unmute at the end, or you can put your questions in the Q&A section in Cvent. So the chat is disabled in Zoom itself. So please use the Q&A function on Cvent through the Summit webpage for any questions. And as they come, feel free to put those in the Q&A box, and we can get those filtered into Christina at the end of the session. You're welcome to have your camera on or off. It may affect your bandwidth, therefore your video and audio. So that's totally up to you. If you lose connection to the Zoom meeting, feel free to try connecting again using the call-in number, and I can put that into the Cvent chat. There will be a session evaluation available and an overall summit evaluation for you to complete. You can find that in Cvent on the session here that you're attending. In the right column, it'll say Q&A, polls, and then survey. And you'll just click the little survey at the end of the session, and please complete that for us. And so now with that, I am going to go ahead and introduce Christina. Christina is the Tribal Community Health Provider Project Director for the Northwest Portland Area Indian Health Board. The TCHP project oversees and integrates the Native Dental Therapy Initiative Project, the Community Health Aid Project, and the Behavioral Health Aid Project. As a project director, she and her team work with the tribes in Oregon, Washington, and Idaho as they explore opportunities to improve the system of healthcare through the implementation of the Community Health Aid Program. She was previously the Native Dental Therapy Project Director and worked in that capacity to improve oral health access and outcomes in their tribal communities, with the expansion of the dental team to include dental health aid therapists. I'm going to put the rest of her bio into the chat for you guys to read that, because she is has done some amazing things. She's been a great mentor to me and confidant, as we at the Southern Plains Tribal Health Board are also kind of doing some chat work. So at this point, I want to hand it over to Christina.
Thank you. Thank you, Julie. Good morning, everybody. Can you all hear me okay? Great. Yes. So I'm going to go ahead and share my screen and hope that this works the way it's supposed to. All right, I believe, oh look, and it got to the most boring part. Okay. And now I'm going to, there we go. So hopefully you all can see my slides in the fancy view. So as Julie said, I'm Christina Freed-Peters. I have the privilege of working with the 43 federally recognized tribes in Washington, Oregon, and Idaho as the Tribal Community Health Provider Project Director. We have integrated all of our community health aid, behavioral health aid, and dental health aid programs under the umbrella of the Tribal Community Health Provider Project, because we wanted our tribes to know that health aides are providers. They provide care in their communities, and they have a scope of practice, and we're going to talk a little more about them. But before we start, I'm going to tell you a little bit more about who we are. So the Northwest Portland Area Indian Health Board was established in 1972. We've been around for a little while. We're celebrating our 50th anniversary this year. We're very excited. And our board is made up of a delegate from each of the 43 federally recognized tribes in our tri-state area. We also house the Tribal Epidemiology Center, and we we have projects that range from Project for Youth, projects specific to diabetes, and just kind of everything in between, seatbelt campaigns, sexual health, all the cancer projects. We also have a education, sort of a summer education program to help our area tribes and other folks out there serving their communities to bring skills back to their clinics. This is our tri-state area. The red is kind of where our tribes are located. As you can see, they range from very urban tribes to very rural tribes. We have large land-based tribes. We have very small tribes, coastal tribes. So it's a big area to cover, and it's a very diverse set of needs for each of our tribal communities. The Tribal Community Health Provider Project, and this is our logo for the Portland Area CHAP Certification Board, which you can see it includes the Dental Health Aide, Behavioral Health Aide, and Community Health Aide project between the Raven and the Eagle, which is the certification board. And that's a visual representation of kind of how the whole enchilada kind of works together. This is our amazing team. So I am really lucky that I don't have to do this work alone. I work with these amazing women and Andrew to implement the Community Health Aide, Behavioral Health Aide, and Dental Health Aide project in our area. So the Tribal Community Health Provider Project, as you can see kind of on this visual, and this slide talks a little bit about when we started putting logos together, we sent out to some of our local artists, and this is the explanation for the artwork that makes up the logos for our project and for our certification board, and then for each of our 3 distinct initiatives. And we also don't do this work, just the 12 of us, as you saw on that slide. We also work really closely with our 43 federally recognized tribes. So we started first with the dental therapy education program and the dental therapy piece. We started our work in 2015, and we put together an advisory work group specific to dental in 2017 to help inform the work that we were doing, so that we were building provider types that would meet the needs of our communities. And that'll make a little bit more sense as I start to talk about kind of what underpins the Community Health Aide program. So in 2017, we put together the Death Hibis dental therapy education program work group. In 2018, we put together the Community Health Aide Advisory Work Group with the charge of providing the foundation for the Portland Area CHAP Certification Board. In 2018, we put together the Behavioral Health Aide Advisory Work Group. And in 2022, we've launched the Tribal Community Health Provider Advisory Work Group to help advise us on the building of the Community Health Aide branch of the Community Health Aide program. It's very confusing. There are lots of acronyms, but I've tried to make it more simple as we go through. Tribal community health providers are dental health aides, behavioral health aides, and community health aides. And this is just a quick sort of overview of what they are. So dental health aides provide a primary level of oral health care. Behavioral health aides do the same for behavioral health, and community health aides and community health practitioners provide a primary level of care. So in rural Alaska, they provide primary care, but they also provide emergent care and other things like that. In our communities here, we're really looking at them as a way to expand access to primary care in all 3 disciplines for our communities. Our board was interested in expanding it through the Community Health Aide program and creating this wraparound health system because we were looking for long-term sustainable solutions that created opportunities for our tribal citizens, created, good paying jobs and education opportunities so that we could lift up our communities and train the next generation of healers and not just bring more providers to Indian country. So why do we need health aides? Well, first and foremost, health aides give great care. They're the backbone of primary care and all care in rural Alaska. The existing healthcare system often is failing our communities. Our clinics are understaffed at all levels, and there aren't very many American Indian Alaska Native providers in our communities. And it's an opportunity to provide the current healthcare education system, which has many barriers to entry for our communities. CHAP is also a unique opportunity, as I said earlier, to expand our healthcare programs in a really thoughtful way, to really sort of dig underneath some of the other social determinants of health that are keeping our communities unhealthy. So we talk specifically about education attainment and economic stability, because these are really opportunities for our citizens in our communities to gain the education, to provide the healthcare. And in some rural Alaskan villages, it's kind of the best job to have because it's a job in the clinic in the village. But in our communities here, since we're not as rural Alaska, it's a really great opportunity for us, because often when you walk into a healthcare clinic, you're greeted by somebody from your community, but as soon as you get behind those doors, you're seeing somebody who is not from your community. So what we really want to do is make the front of the house and the back of the house look the same and have community members available at every step of the way. I talked a little bit about kind of just very broadly what the community health aid program is in the Tribal Community Health Provider Project. So I'm going to start by describing some of the providers available through this program. I'll start with dental. Dental health aides, it's a series of accessible stepwise oral health careers. Dental health aid therapists, which might be the one you've heard the most about, is the top level, and they can provide a pretty broad scope of practice. It's much smaller than a dentist. The comparison is like, if you think about a dentist can provide around 500 distinct procedures. A dental health aid therapist, is in the realm of like between 50 and 100, depending on their supervising dentist and their training. But they can do things, they can do dental exams, they can diagnose and treatment plan. They can restore teeth and not just pull teeth, but they can also pull a diseased tooth in a simple extraction. But they're not surgeons, so any sort of complicated or surgical extraction is going to still go with the dentist. They're really, all of these health aides are a way to expand the reach of physicians and expand the reach of your dental clinics in meaningful ways to provide primary care. Underneath the dental health aid therapist, I started at the top and I'm going to go back from the bottom up. Starting with the primary dental health aid 1. So they're really oral health educators for your communities. There's not any real prerequisites. We've started experimenting with teaching primary dental health aid classes and core curriculum for all of our health aides in high schools, so that we're introducing health careers to our youth before they go out into the world and choose something else. So we've got primary dental health aides 1, and then primary dental health aides 2. So you need that education as a primary dental health aid 1, and then you can take the primary dental health aid 2 level. And at that level, they can provide assistance, but they can also provide preventative procedures in your clinic, and they can work under general supervision within their scope of practice. Expanded function dental health aides are like if you have expanded function hygienists or expanded function dental assistants in your clinics currently. An expanded function dental health aide can also place simple restorations. The difference between an expanded function dental health aide and like a dental health aide therapist is a dental health aide therapist can start that restoration from start to beginning. So a dental health aide therapist can diagnose that carie and remove the decay and fill the hole, and then provide follow-up treatment. Expanded function dental health aid level 1 and level 2, they don't diagnose, they don't drill out the decay, but they can place that filling once the dentist or the dental health aid therapist has removed the decay. And then there's a dental health aid hygienist, which isn't very often used. It was created in Alaska because the local hygienist couldn't place local anesthetic, and that was a challenge for the Alaska health system. But then they changed their law, and so largely dental health aid hygienists are not used. behavioral health aides, there are 4 levels of behavioral health aides. And as I said before, it's stepwise training, so they grow upon each other. So you start out as in the behavioral health aide 1 training. And let me back up a little bit. The only one that's a little bit different is the dental health aide therapy training, where you can start the dental health aide therapy training. It's in Washington, it's 3 academic years that we've condensed into 2 years, and you kind of go all the way through. You don't really start as a primary dental health aide and then become a dental health aide therapist in the same way that you will for behavioral health aide and community health aide. Behavioral health aide 1, so you go through the behavioral health aide 1 education program, and then you spend some time in your clinic or with your supervising provider practicing your skills and doing a preceptorship. And when you get really good at that, you come back for behavioral health aide 2. And as you can see, at each level, your scope of practice grows at each level. By the time you get to the practitioner level, you can provide all the services from behavioral health aide 1, 2, and 3, as well as team leadership, and you can supervise other health aides. Behavioral health aides are really important in communities that are struggling with access to behavioral health care. They're also out in the communities doing different types of programs, so they can lead, if there's been a death in your community, they can lead community grieving. They're in schools, and they really provide a lot of support for behavioral health aid programs around the state, around our 3-state area. We currently in our tri-state area have a behavioral health aid training program for levels 1 and level 2. We are in the process of building out those upper levels of level 3 and practitioner. But right now we have students who just graduated from level 1, and they're going to be starting level 2 this year. And then we have a new incoming class of behavioral health aid 1. So we're still in the process of building our programs here, and we're a little bit building the plane while we fly it, as we talk about, but we're also being deliberate in trying to see if what we're doing is working. And so experimenting a little bit on this first group of students, this first cohort of students, to make sure we get it just right. So as we work on it, we're kind of dialing it in. The community health aides, it's the oldest branch of the community health aid program. Like I said before, the community health aid program was developed in Alaska over the last 60 years. And so it's the most developed in Alaska, and it's the practitioner that's the most used in Alaska. Dental health aides and behavioral health aides came in after 2000. So I believe dental health aides came in around 2000, like the early 2000s, and then behavioral health aides came in kind of in the, well, it's still early 2000s, but closer like into the teens. So they haven't been around as long. So there aren't as many in their communities, but they're equally as valuable. So as you can see, the sessions build upon each other. There's 4 weeks. That 4 weeks is the didactic training. So each health aide, let me back up a little bit. Each health aide is hired by their village council or by their community. They then go into pre-session where they learn about what the community health aide role is. They also learn about a document, well, it's a book actually, it's the Community Health Aid Manual. And for behavioral health aides and community health aides, they use those manuals as they provide care. They also get ETT or EMT training, because when they're out in the villages, they are the first responders in their communities. That might look a little different in your communities if your communities have access to emergency care through 911 or through your existing health system. So for example, many of our health aides won't need that role as ETT or EMT, and ETT I think is specific to Alaska. It's like emergency technician. And I think you all know what an EMT is. It might look a little different in our communities where we don't really need that emergency because we have access to emergency services. And so we're really gearing the training for our health aides more around primary care for our elders and for our youth, well, childs, pregnant mamas, things like that. So that session 1, so you have 4 weeks of didactic training, which is the book learning piece of it. And then they do some clinical work through the course of their training. And then they go back to their home clinic and they spend 60 hours in the village clinic to complete their post-session learning or their preceptorship. Once they've done that and their supervising instructor has signed off on their clinicals, they are then eligible to do session 2. So they can hang out in session 1 as long as they want to, or as long as that clinic needs somebody at at that level, or they can go straight on into session 2, which is another 4 weeks of didactic training. But at session 2 is when their scope of practice really changes, and they have a lot more within their scope of practice. So as you can see, the in-clinic hours really jumps up as you start getting deeper and deeper into that training, because the scope of practice really grows. I'm going to move on to the next slide because it talks a little bit about kind of what they're learning in those different sessions. So as you can see, session 1, it's pretty basic, body systems, medical history, basic exams, basic anatomy, and they're doing really simple skills. I say simple, but I'm not a healthcare provider. They start to learn a little bit about mental health and substance misuse, because they are in those clinics, they are the providers in their clinics. But as they start getting into session 3, then they're looking at prenatal visits, well child visits, women's health, STIs, things like that. They're also at every level, because health aides are the emergency providers in their communities. They're also reviewing that emergency technician training. With behavioral health aides and community health aides coming into or behavioral health aides and dental health aides coming in, there's not a focus on mental health for community health aides, but they are still learning to provide basic services for somebody in crisis, because they are the first responders in their communities, but also it's a small community, and providing they're really the frontline providers in rural Alaska. We are as we build our programs out in the Pacific Northwest, we're really looking at ways to help integrate some of the early training, so that each of our providers are getting some behavioral health training, some community health training, and some dental health training, but really as they go through the levels, specializing into one of the 3 disciplines. The other thing that is going on for them in these sessions too, that isn't included in the slides, is some healthy healer or self-care work, because it is very hard to be the only provider in your community, which is the case for often in Alaska, but or maybe there are a few health aides in the clinics. But also it's hard to provide care to your community, to your cousins, to your frenemies, to really everybody. So we really want to make sure that our providers are gaining access to some coping skills and other things like that as they deal with traumas and they deal with the health of their community. Session 4 gets more into chronic illnesses. And so, like I said, by the time you get to session 4, you've done session 3, session 2, and session 1. So your scope of practice has been building all the way through those levels. But by the time you get to session 4, you're doing that chronic illness care. You're getting some specialized training around elders, tobacco cessation, substance misuse. You're reviewing that ETT again, and you're also a clinic leader. So there's a fair amount of training around clinic leadership and mentorship that goes into that last session. After session 4, they do a long preceptorship, and once they complete that preceptorship, they're then the community health aide practitioner level, which is the top level of community health aides. Community health aide integration. So when we talk about health aides broadly, sometimes we'll refer to them as tribal community health providers or just broadly as health aides. But there are a lot of benefits to integrating health aides into your communities. And as Julie said, this is the first session, and we're going to talk just really broadly about health aides. And then in later sessions, you're going to dig down into some of those different providers. But, for the nice part about health aides, or the thing that's different about health aides than other ways to expand access to care in your communities, is that it creates jobs, and it creates professional wage jobs. It creates education programs in your communities, and it really keeps your talent in your community rather than having them drown out of the community. Ideal health aide candidates have a high school diploma or the equivalent and the desire to serve their communities. You also need to have supervising providers, which could be really hard if you have a very small health clinic or a very small health system. And one of the nice things about the community health aide program and the way that it's utilized in Alaska is a hub and spoke model. So even if you have a large land base, or if you have a really small health program, there are opportunities with the health aide program to expand access to care with like supervising providers in a hub clinic or a hospital, depending on what your health system looks like. We don't have hospitals in the hospital in the Portland area. That we do have hospitals, but not one that's a tribal hospital like they do in Alaska and other areas. But we do have some larger health system pieces that could go into a hub and spoke model, but we're still feeling it out here, what it's going to look like for some of our clinics. But some of our larger land-based tribes are really excited about the idea of having like their supervising providers in a hub clinic, and then having community health aides, behavioral health aides, and dental health aides out in smaller sub-regional clinics. Dental health aides, community health aides, and behavioral health aides just increase patient access to healthcare in your communities. A health aide visit is a much more in-depth visit. So some patients miss the days when they could spend a half an hour or so with their doctor and kind of talking through their health and getting the care that they need. So an exam from a health aide is much more in-depth than an exam from a physician assistant or nurse practitioner or a doctor. So it provides a different type of care. It allows the integration of some of your more traditional practices into your community health settings. It reduces workload on other healthcare providers so that they can focus on more complex patients while increasing access to primary care in your communities. We believe that it improves continuity of care. One of the things we see a lot in our health clinics is we do have a lot of relationships with the different medical schools and dental schools in our area, but what that means, and with loan repayment kind of exacerbates it, we get brand new providers who come into our communities and they spend 3 or 4 years paying off their loans and getting really good at their jobs, and then they leave, and then we get another new doctor or dentist who comes in. Those community health aides, behavioral health aides, and dental health aides tend to stay in their communities in the long run. So as supervising providers come and go, and master's level providers or doctors and dentists come and go, those health aides remain in their clinics and remain in their communities and provide that continuity of care. So the benefits to the community are in increased career opportunities, career advancement opportunities. One of the challenges that our communities face is our graduation rates and our college graduation rates. So this really looks at the way that health education is done, and tries to strip away some of those barriers that our students are facing when they want to enter the health careers. And it allows students to work while they're in their education programs. So, not all of us have the privilege of being able to leave our homes and quit our jobs for 4 to 7 years in order to get these degrees. This allows them to stay at home or close to home, get their education, work while they're doing it, care for their families, be engaged in subsistence activities or traditional gathering activities, hunting, fishing, those types of things, while still getting their education. It also offers the possibility for new clinic offerings with additional staffing. So you can have extended hours or additional services. You can, like I said, start integrating some of those traditional practices into your communities. You can be really creative. And the clinics that we see where their supervising instructors and their health aides are working hand in hand to really improve their health programs are the ones that are thriving the most. Health aides are from their community, so they know what the challenges the community is facing, and they know the challenges the community faces in trying to access care from their home clinic. So they're a great resource for clinics who really want to expand access to care and provide better services for their communities. It also increases the likelihood of filling those open healthcare provider positions. I don't know what your area is like, but in our area, there are often many vacancies. And so using health aides to fill vacancies is a great way to expand access to care and have consistent care in your communities. So I talked about the Tribal Community Health Provider Project and the way that we do our work. We are not doing it alone, and we're very grateful for the tribal leadership from our 43 federally recognized tribes, as well as their clinic leadership. Our tribes have been very generous with letting us pull their doctors and their dentists and their health administrators out of clinic and into meetings so that we could create advisory work groups to really help us understand what the community health aid program is going to look like in our area. I'm going to talk a little bit about the regulatory structure. The community health aid program it's an education program. It has a regulatory infrastructure, so it sits outside of state regulatory bodies, so that it allows the tribes and in the area more flexibility in terms of what their providers look like. And it's providers, so it's healthcare as well. So it's all of those things. And the way that we have it set up is we have the Tribal Community Project, and we We take advice from our 43 federally recognized tribes. We have a Portland area CHAP certification board, which we have created in collaboration with the Portland area Indian Health Portland area Indian Health Service. We also provide technical assistance, and we sit on the Community Health Aid Program Technical Advisory Work Group for IHS. So we're also working to help influence that national policy that underpins all of our programs. And then we have our behavioral health aid, dental health aid, and our newest branch that we've been working on, the community health aid education programs. So I'm not going to go into all of our different work groups, but essentially, so I'll talk a little bit about our tribal community health provider work group, which is right now our most active work group, because we've just started the work to figure out what the community health aid program is going to look, the community health aid branch of the community health aid program is going to look like in our area. So it ensures the voices of our tribal leaders, our tribal health directors, our clinic staff, and medical experts are at the table while we're developing the scope, the education pathways, and other nuances or specialty tracks and things like that for the role of these new providers. It is for us here in the lower 48, it is creating a new wraparound health system, and it's not that easy to just drop a brand new provider into a clinic. And we've learned that with our dental health aides and now our behavioral health aides, is that, you know, clinics they've been doing business the same way for many years. And so bringing new providers in isn't as simple as just plopping someone in the middle of the clinic, say, go forth and provide care. So we've done a lot of training with our clinical staff and others about how to integrate new providers into their communities. We also work really closely with the Medicaid agencies in our state as well, because we really are integrating these providers into our healthcare system. The goals of our work groups is really to provide advice and expertise about the way community health aides and community health practitioners can fill healthcare gaps within our tribal health system, and really to make sure that what we are doing at the Portland area board is hand in hand with our tribes. And so we didn't want to build a program kind of in a vacuum. We really wanted to build a program that was going to fit some of the gaps and meet some of the needs that weren't being met in our communities. What that means kind of at the nitty gritty is we've been going through the Alaska Community Health Aid Standards and Procedures, and I'm going to talk a little bit more about what those documents are and other documents to really understand what they are in Alaska. So we've done a lot of work over the last handful of years around educating our tribes and educating our tribal health programs about what these health aids are. We didn't start, we're not building something from whole cloth. We have the great example of the work that they've been doing in Alaska over the last 60 years. And so we started by looking at their standards and procedures and adapting them to the Portland area. The standards and procedures holds all of the information about the education programs and the scope of practice and supervision requirements. And then we adapted those to the needs of our clinics. So, you know, what that looks like is kind of a line by line going through of those standards and procedures to create our own standard procedures, but also they're really long, fun, and philosophical conversations about what's missing from our healthcare system, what we would like to see in our healthcare system, and what fits within the role of a community health aide and building it up that way. So now I'm going to talk a little bit about the regulatory infrastructure that underpins all of this. So we've been doing this work since 2015. That's when I came to the board. And by 2016, so let me back up. In 2010, with the passage of the Affordable Care Act, the Indian Healthcare Improvement Act was permanently reauthorized as part of the Affordable Care Act. In there were a few lines that allowed for the nationalization of the community health aid program. So that was in 2010. In 2016, really due to the advocacy from the tribal leaders in the Pacific Northwest and other tribal leaders through NCAI and NIHB, IHS finally initiated consultation on the community health aid program and whether or not tribes are interested in nationalization. It was overwhelmingly supported to establish a national CHAP. And so the work started in 2017 and 2018 with IHS. Meanwhile, in the Portland area, we had started building infrastructure. So we started with the dental health aid therapy program, and we were building an education program. We sent a handful of students to Alaska to get trained so that we could really see what it meant to have these health aid providers in our clinics. We sent some brave men and women to live for 2 years in Alaska, and then they came home, and we spent a lot of time asking them how it's going, asking the providers how it's going, tweaking things, figuring things out, and we have learned a whole lot from those first providers who went to Alaska to get educated. We now have our own dental therapy education program here in Washington, and it services Washington, Oregon, and Idaho. We also have students who are interested from other states, but they're small classes, so they're limited seats, but it's a program that's open to all. We have dental health aid training at all the different levels, but we do that in collaboration with the tribes in their clinics. So we have trainers that are part of our staff who've been going out providing that curriculum. The behavioral health aid is a little bit different. So for dental health aid, we work with Skagit Valley College and Swinomish Indian Tribal Community. For behavioral health aid, we're in partnership with Northwest Indian College and Heritage University, which is a college on the lands of the Yakima. And then we work closely with the Yakima tribe and Lemhi Nation, and then some of our other tribes, Umatilla and a few others in that area, to provide that behavioral health aid training program. The community health aid training program we're building out now. So we've just started working on that. And those programs, we're working again with Northwest Indian College, and we're exploring maybe some pilot projects or maybe some other smaller in-clinic programs with some of our local tribes in Oregon and Idaho. We're really trying to figure out how to get the training closer to home, because one of the limitations is obviously leaving your community to go train. But let me get back to our certification board and our timeline. So we started going through the Alaska Standards and Procedures. After putting together we sort of developed a Portland Area CHAP certification board and what that would look like, and the different types of seats that would fill it. We started working on the Portland Area Standards and Procedures, which is the document that underpins all of the health aid programs. In 2020, IHS Circular 2006 established sort of the underlying policy for what health aid programs would look like in the lower 48. And in 2021, our Portland Area CHAP certification board was officially seated and started having meetings and accepted our standards and procedures and created some other infrastructure for it. The goals, so the Portland Area CHAP certification board is pretty specific. They don't do a lot of things, but what they do is very important. They provide certification for community health aides, behavioral health aides, and dental health aides. They also certify the education programs. And again, those standards and procedures are the guiding documents for those pieces. They also approve all continuing education. Tribal community health providers are required to have continuing education throughout their career, just like any other healthcare providers. And also the Portland Area CHAP certification board is very interested in creating a system that's going to address different health disparities. So all of the work that they do through the lens of addressing health disparities, health equity, and education equity for our communities. I talked about the standards and procedures. In Alaska, it's a few hundred pages, and in Portland area, it's a few hundred pages as well. We adopted ours at the end of 2021, and that was after a thorough line-by-line review of the Alaska certification standards and procedures requirements, and many hours of deep thought and discussion about what we wanted a health aid program to look like. So the standards and procedures, there's a little snapshot here of what types of things are in the standards and procedures, but really it's the document that says what the training requirements are, what the supervision requirements are, and also goes into some other pieces around like the certification board, the education programs or the training centers, and what are their requirements. So if you think about like in your state, maybe the Dental Practice Act or those regulatory pieces that underpin your medical system, it's the same sort of thing, but I don't want to say it's in miniature because it's a big undertaking, but it's very specific to the health aid program. And so the certification is akin to like state licensure. These providers are not required to get state licensure because they're overseen by the certification board. And each area will have the opportunity to develop their own certification board and their own standards and procedures based on federal baseline standards that are in development now with IHS. Our certification board also has bylaws, which really covers our mission and our vision. It's the specific document around meetings and membership and meeting protocol and things like that. And we've got our meeting schedule there for 2021 and 2022. If you ever want to come to a Portland Area CHAP certification board, they're quarterly. And our next meeting, I believe, is in November. And I think we're going to attempt our first hybrid in-person and over Zoom Portland Area CHAP certification board meeting. But because all this work started with the certification board during COVID, all of our meetings have been virtual up to this point. The other piece that's really important for the community health aid program are academic review committees. Academic review committees are a body of experts that oversee the curriculum and ensure that our providers are always learning sort of up-to-date medical, dental, or behavioral health care for their communities. So they review the curriculums, they do a regular review of all the curriculum, any curriculum changes will come out or come through the academic review committees. And there's one each for community health aides, one for behavioral health aid and one for dental health aid, and they're all separate because they're made up of experts in that field. For more information about our program, you can go to the www.tchpp.org, or you could start at the Northwest Portland Area Indian Health Board and you can find your way through. But in there, you'll find a wealth of information about each of our different health aid programs. There's also more information about our certification board and other pieces. We also participate in the Indian Country ECHO project with a CHAP Learning Collaborative. So that's another place. On our website, you can see all the past ones, but you can also on the ECHO website too see all of the past webinars that we've provided that really go in depth in each of the different provider types. So if you're really looking for more information, the IndianCountryEcho.org is a great place to find some more information. And the CHAP Learning Collaborative, I believe, is every other month, and we pick topics based on the questions that we get. So we get a lot of questions from folks around the country and then questions from our tribes about what it is. And so when we start getting sort of a critical mass of questions, we'll create a webinar about it. If you ever have questions or you're looking for us, these are the email addresses of our team. We're always happy to help. Laura's email got a little cut off there with our logo, but we're always happy to help. We are excited about our work. We love our work. We're learning and growing along the way. And we're always happy to share the information that we have. And I believe that is my last slide. So I will stop and pause for questions. And I will stop sharing my screen.
Thank you so much, Christina. That was such an awesome presentation. I have so many questions and notes, but I just want to remind everyone that the Zoom chat is disabled. So please head over to CVent to the SBTHP Training Summit website and put your questions in the Q&A feature that you can see on the right side panel. So looks like we have a question from Chevy. What led you to become involved with the Tribal Community Health Aid Project, or CHAP? Was it a specific event? And how can individuals assist their communities if communities do not have a CHAP?
So the CHAP journey in our area was interesting. It started with dental health aides. One of our tribal leaders had gone to a meeting by, I think it was the Kellogg Foundation, where they learned about the community, well, specifically the dental health aid therapist. And he sort of walked out that meeting thinking, why can't we have that? And so folks who came before me, I think so his team and then folks at the Northwest Portland Area Indian Health Board started looking into it. And that's when they discovered there was this nationalization language. And I had been working on another project in collaboration with the tribes. And so that's how I personally became involved. And they were like, hey, go to Alaska and figure out what this thing is. And so I went to Alaska and I went with some tribal leaders and some other staff that were, again, staff that came before me. And we really started to look at what we were looking specific to dental health aides, but as we were looking at it, we were learning about all of the different pieces of the community health aid program. So as we were educating our tribe, our 43 federally recognized tribes in our area, we wanted them to understand that dental health aides were part of a larger system. And as we were talking about the larger system, our tribal leaders in our area said, well, we have a huge mental health crisis, so we want behavioral health aides, and we have a huge primary care crisis, so we want community health aides as well. And at that point, our team started to grow as we really started to figure out what these providers were and how they could be integrated into our community. So it was really kind of an organic, a tribal leader learned about something, thought, I can care for my communities better if I have access to this. Let's figure out what it is, to where we are today. If you're interested in bringing this to your community, it starts with education. Utilize like forums like this or the Indian Country Echo with our CHAP collaborative to learn about what these providers are. So what we found is, our communities know that their healthcare systems, how their healthcare systems are failing them. And so we spent a lot of time just talking about what the community health aid program is, because that was really the first step. I think if we had just plopped a community health aid in the middle of a community health program, they would have been like, what's going on here? So it might not have been as accepted, but folks now are excited about expanding our health systems to include community health aides after a good 2 or 3 years of education around what a health aid is. And it's a continuous education process. They say somebody has to hear something 3 times before it sinks in. But there's a lot of ownership now from that education. We've taken tribal leaders initially to Alaska, but now we take them to our own training programs. We have different providers working in different places. So we do a lot of road shows in our area so that we can show kind of proof of concept. So there are a lot of ways to kind of grow that support within your communities as well. But it starts with education. And if you're in Julie's area, it starts by calling Julie.
Yeah, and I wanted to add on to that, to your answer, Christina, is that so in the expansion of the CHAP program from Alaska, I do want to mention that the Northwest Portland area is receiving funding to implement, which is kind of what Christina has talked about this last 45 minutes. And so actually here in the Oklahoma City area, which includes Oklahoma, Kansas, and Texas, the Southern Plains Tribal Health Board and 2 other tribes have received funding to assess tribal readiness for CHAP. And it's the Tribal Assessment and Planning grant, which we're working through. And so, Chevy, to kind of to go along with your question, we're currently working on talking to communities, talking to tribal leaders to kind of understand more of the landscape and to kind of get a baseline of our area, because every area is different, every tribe is different, and so there's a lot of variables and a lot of different questions and kind of education and data gathering that has to go into place to really assess how this program will be implemented and unfolded. So like Christina said, it's like you can't just train or just drop a community health aid provider. There is a lot. So we are working on that, and this is kind of one piece of that puzzle that we're kind of putting together in bringing Christina in and kind of doing that education. And it is something that we're working on constantly. So the wheels are in motion here in the Oklahoma City area for those attendees that are here from that area. It's just Northwest Portland is they're a few steps ahead. So, but it's great because they've got a lot of wisdom to share and a lot of insight. So I don't see any other questions in the Q&A chat here. So I'm going to jump in and ask one because we do have a few minutes left. So Christina, how difficult was it to adapt the standards and procedures from Alaska? I know it's like a super arduous process going line by line through 100 pages. And so not only are you doing that, but you're working with the other tribes and the other tribal health systems. So how did, and I know you had mentioned like, you had your work group and you had a group, but I'm just trying to get an idea of how difficult it was to take this massive document and apply it to not only your area, but all the tribes and to adopt that. What did that process look like?
It was surprisingly fun, but that's because I'm a little bit of a nerd. But it was surprisingly fun too, because when you get a whole bunch of health professionals and health administrators and tribal leaders from your area into a room and you start saying, tell me what your ideal healthcare system looks like what's missing. So we had some really great conversations on the front end where we just kind of like dreamed big. We're like, okay, we got no limitations and our healthcare system can look like anything we want. And people have been thinking about this for a really long time. So we started out with kind of having those types of conversation. And then the requirement is that you can't go below the Alaska standards. So we looked at what the scope of practice was for those individuals. And we're like, okay, we're going to start here. What more do we want? And also what doesn't really fit with our health system as well. I talked about the emergency training. They're probably not going to need that kind of training because most of our tribes have access to 911 and other emergency services. So once we kind of had those baseline conversations about what we wanted our healthcare system to look like, and everybody kind of went through the standards and procedures as they are so that they could understand what these providers could and could not do at the different levels. That's the point where we then started that line by line process where we're like, and sometimes it was just as simple as changing the word Alaska to Washington, Oregon, and Idaho. Other times we really wanted to build in more around, the standards and procedures in Alaska are continually updated, but we wanted a lot more language in ours around cultural competency, historical trauma, and those other pieces. And so we were able to build a lot more of that into our healthcare system. So, the process was tedious, but I think folks enjoyed it because I think that and you'll probably find this when you start getting on your communities, people have been thinking about their healthcare system for a really long time, and they have a really good sense of what is and isn't working and what they would like. And so I feel like it gave an outlet for our health professionals and for our tribal leaders to finally feel like they were going to be able to make some real change in their community. So we were surprised at how engaged folks were in that process.
That's really, really good to know. So Chevy said, thank you, Miss Christina. The wheels are turning in my mind on how I can help more with an IHS facility I assist. Good thing I know Julie. I'm not sure I'm much help now, Chevy, but hopefully I will be. Okay, and I'm not seeing any questions in the Q&A yet. And we kind of have a relatively small group, so feel free if you prefer just unmuting and want to ask a question. We have maybe just a couple of minutes left before we need to transition to the next session. So I'll give it just a few seconds if you guys want to unmute or if you want to put another question in the chat.
I tried to be really thorough, Julie, so.
You did a fantastic job. And I was going to see, could we get a copy of your slides?
Yeah.
Are you able to share those? Okay, and then we'll get those to the attendees.
Well, usually I only get like 20 minutes, so I try to condense all of that into 20 minutes. So when you said you have an hour, I was like, yes.
And you just scratched the surface too, because I know there's so much more. So even an hour, we didn't get all of it, which is why we're kind of breaking the sessions up. So I do want to tell everyone here on the call, if you want to just hop over to the next link to the next session, we're going to talk a little bit more about the policy aspect of the community health aid program, the federal policy, and some limitations that are involved with that. We've got Laura Hale Brannon with Community Catalyst that's going to talk. about her and her experience with tribes in this area. And also we'll hear from Brett Weber from the National Indian Health Board, who's really involved in advocacy and chat policy. So we'll be able to talk about that. We'll also hear from our very own Bruce Pratt, policy analyst at the Southern Plains Tribal Health Board, to kind of give us an Oklahoma perspective. So be sure to check in with us over there at the next session. And we'll finish just a couple of minutes early to give folks a chance to kind of transition. I want to remind everyone to please complete the survey for this session, please, so we can have that feedback. Also, don't forget about the overall summit evaluation that's going to be on that homepage whenever you log in. I want to give my many thanks to Christina for all of her hard work and for this presentation and all the information, and we'll get everyone the slides, and yeah, more to come for sure. So all right, well, thanks everyone. Have a good rest of the day. Hopefully we'll see everyone soon in the policy session. Thanks, Christina.
Thank you. Have a great day. Bye.
Bye-bye.